Thanks so much for everyone for turning out, especially on Pride weekend. I know there's a lot of competing events going on, so we appreciate you spending your evening with us. My name is Jeff Taylor. I'm the Community Engagement Coordinator for the RID HIV Collaboratory. My group, the HIV and Aging Research Project, Palm Springs, is the community engagement partner for RID. Each collaboratory has a community engagement partner, and you'll hear later from the local one, Sister Love, that works with the race here locally. So first, I want to do just a little bit of housekeeping before I turn it over to Andy here. If you didn't already, you should have gotten at least 2 drink tickets for wine and beer to go with your meal and to enjoy during the program. And if you didn't, just go to the front desk there, and the lovely Corrine will they give you some. And then afterwards, when the program ends, we will be having a reception and cocktail hour, and there will be a signature cocktail. You'll hear more about that later. And so there'll be plenty of food and drink, so you won't need more tickets for that. We were just trying to limit those in case we got a huge, overwhelming turnout. So any other housekeeping issues would be the restrooms. So go back in where you came and then past the desk and to your right to get to the restrooms. And I'll turn it over to Mr. Andy Cates, the co-chair of the RID CAB.
Hello. Thanks, Jeff. One thing that Jeff likes to say a lot that I think he's giving me the honor of saying is make sure your phones are in pleasure mode. Just so that everybody, so that we don't interrupt the speakers. Yes, I'm a co-chair of the Community Advisory Board for RID HIV, and unfortunately, I have to be the only co-chair. Meaning there's my co-partner, and she's not here. It's Lisa Diane White, who's also with Sister Love, and she unfortunately had a little health issue that she could not be with us this evening, and so I was counting on her to welcome all of you. The cocktail that we're going to be having at the end of the night is kind of based upon what we do here. It's the cure cocktail. So just like the research, it's really beneficial, but it's not anything that you're going to benefit from. If you imbibe too much, there may be some risks involved. But if you sign the informed consent, there's not much we can do about it. However, we will be able to give you some aspirin a little bit later, and that's about as far as we can go with it. But anyway. What's that? Yes. ATI would be good for that in recovery. But anyway, I am really glad that you're all here. And yes, thanks for being here on a busy weekend. And we hope you enjoy the program.
Great. Thank you, Andy. And next, we'd like to thank our local co-host. Yes, applause for Andy. He's playing all week, so so come on up, Puri Bandari from Sister Love, and they have been our wonderful partners and collaborators in putting this together. As I mentioned, our group is in Palm Springs on the other side of the country, so that we could not have done this without their help. And so Puri will introduce herself and talk a little bit more about.
Hi, everyone. My name is Puri Bandari. I'm the Community Engagement Coordinator for Sister Love. For those of you who don't know, our mission is to eradicate the adverse impacts of HIV, as well as those of sexual and reproductive health rights and justice challenges that impact women and their families. We do that through many different approaches. We offer free testing, education, prevention, support, as well as advocacy, both locally here in Atlanta and globally. So yeah, we just wanted to give a big thank you to the RID Collaboratory, the RID CAB, the Erase Collaboratory, the Erase CAB. We want to thank Tito's for the cocktail that Andy was mentioning, and Dr. Suckley for generously donating wine. But yeah, and and I want to give an even bigger thank you to Jeff here for coordinating all of this and putting so much effort into this event. Thank you. I think Maeva, our chair of our Erase CAB, will be introducing herself as well.
Yeah, so go ahead and Maeva Blackwell, make sure she's unmuted, and she's going to introduce herself. and do the
Everybody,
land
hello
acknowledgement.
everyone. Can you all hear me?
I'm Ava. There you are. Can you see us?
Yeah, can you? Yes, I can see you. Can you
Okay, give
hear
us a
me?
minute. We'll make sure we get you up on the screen so we can see your lovely face. There you are.
Hi, can you all hear me?
Yes.
Great. Thank you all for the privilege of giving the announcement here regarding the land acknowledgement. And that is because Emory University acknowledges the Muskogee people who lived, worked, produced knowledge on, and nurtured the land where Emory's Oxford and Atlanta campuses are now located, also known as Muskogee Creek. In 1821, 15 years before Emory's founding, the Muskogee were forced to relinquish the land. We recognize the sustained oppression, land dispossession, and involuntary removals of the Muskogee and Cherokee peoples from Georgia and the Southeast. Emory seeks to honor the Muskogee Nation and other indigenous caretakers of this land by humbly seeking knowledge of their histories and committing to respectful stewardship of the land. Thank you all.
Great. Thank you, Maeva. So thank you for being able to join us remotely. I know Maeve is in DC, so we appreciate her coming on and joining us, and she'll come back on at the end as we say our thank yous. So next up in the program are going to be why we're talking about a cure-it-all. So if we could ask Adam Castillejo and Paul to go up and sit in the hot seats there. And I'll do a few words of introduction to them. So, you know, those of us who've been around with the epidemic for the last 40 years know that early on, there were a lot of kind of false promises around a cure. They said, oh, we'll have a cure in 2 years. Jonas Salk famously said so. Margaret Heckel, David Ho, a number of years later, was on the cover of Time magazine saying that if we all took our pills, we'd eventually end up cured. We all know that wasn't true. There's a lot of false hope. But then there was a guy named Timothy Ray Brown, better known to the press as the Berlin patient. And this was a guy who, an American guy who was living in Berlin. I know him very well because he and his partner moved to Palm Springs a few years ago, and we got to know him very well. But Timothy had cancer, a kind of aggressive leukemia that did not respond to chemo and radiation. Cancer treatments were working, so his one hope was for a bone marrow transplant. And he had a brilliant oncologist in Berlin named Gerhard Hutter, who had read the literature. He was not a researcher, even an HIV doctor, but he knew about the fact that there were a number of people with this rare genetic mutation in their blood. And he thought, you know, if we're going to be giving a transplant, why don't we see if we can find somebody who has this, and maybe we can cure not only his cancer, but his HIV. And lo and behold, it worked. So Timothy became the first person in the world who, and I get choked up about this, was cured of HIV. But unfortunately, we lost him a few years ago. His HIV was cured, but his cancer came back. And so about 2 years ago now, going on 3 years, it was during the COVID pandemic, we lost Timothy. But fortunately, others have watched the work, and there have been a number of other people. And we're fortunate to have two of them here today, Adam Castillejo and Paul Edmonds. So we'd like to welcome you and thank you for coming. So Adam was the second person officially cured of HIV. So go ahead and tell us a little bit about your story, if you would.
So yes, I have, as a lot of people know, my story a little bit. I was diagnosed with cancer in 2011. Then that story by HIV happened in 2003 when I was diagnosed with HIV. So there was kind of two different similar stories. I have a death sentence twice, but one we love and one we hate. So when I had the cancer diagnosed, everybody loved me, everybody support me. When I had the HIV diagnosed, it was shameful, it was hate. So I had to hide away from that one. So it's two different ones. So my journey as the London patient, as Jeff was talking about, we are here, I'm here, and Paul as well, because Timothy Ray Brown. So without him, we would not be here today. Our stories. My story is just I was a normal guy who just happened to have cancer. And I had this opportunity in 2015 to have a bone marrow transplant for my aggressive Hodgkin lymphoma. So that was really complicated for me, realizing that for the first time in a long time, HIV, I was discriminated not to even have a transplant because I was HIV. So my journey, you learned that both illnesses, they are side by side, but they have different priorities, stigmas, and that was quite a journey to understand the difference between cancer and HIV on the context. And then I had the opportunity to replicate what Timothy had. They say to me, Adam, you have the opportunity to cure your cancer and your HIV. And I went like, what? In my lifetime, I would never thought I was going to even cure, because in our mindset, it tell us it's impossible to cure HIV. When I had been the opportunity for me, it was a mind blowing. And from that point, kind of, I felt the empower and I felt the responsibility to science to help our community, my community, to help. And I think that through the last couple of years, my journey has evolved. If somebody asked me 10 years ago, I would be sitting here today talking to you. I think, well, are you crazy? But here we are. So, you never know what happened in life. And for me now, being the London patient and being the second person to be cured of HIV, it means a lot to me. It means I can empower people. I can give hope to people around the world and inspire you guys to continue your research, continue to work, because I'm the living proof it's possible to cure HIV. My cure, as we all know, is a proof of concept. It's not feasible for everybody, but at the same time, it's the window, is an open opportunity to find a cure for everybody. So my story is about resilience, it's about hope, and being a human being, because after all, we all human beings. So that's Adam the London patient.
Great. Thank you so much, Adam. And we're going to be hearing more. I'll be asking questions so you get hear a little bit more about each Adam and Paul. So next up, Paul Edmonds, better known as the City of Hope patient, whose cure was just announced last year at the International AIDS Society meeting in Montreal. We'll let Paul get set up and
I have some pictures, but I just, we forgot the pictures. So this is me just before that. Okay, go back quickly to before. That's me before I had cancer. That was me in 2011. So just living my life as HIV, because I didn't have HIV to define me. That's one of the things I never allowed to HIV to, despite all the struggles. And then the next one, this is the day of my transplant in 2016. That's the day my life changed. And that's when the story of the London patient began on May 13, 2016. And the last one is now. That's one today. So that's my pictures.
Hello, everyone. I hope you're doing well today, and thank you for inviting me here. My name is Paul Edmonds, and I want to take a few minutes to talk about something that's completely changed my life, having my HIV in remission. I am the City of Hope patient, the 5th person in the world to have HIV and leukemia in remission after a bone marrow transplant. I moved to San Francisco in 1976, and I was 21 years old. I came from a small town in Northeast Georgia. It was like heaven moving to San Francisco. This was my first gay pride parade in 1977 during the Anita Bryant days. In 1988, in 1980, people began getting sick, and it was being called a gay cancer. In 1988, I got tested, and I was HIV positive and received an AIDS diagnosis because of my low T cell count. In 1992, I met my future husband, Arnie House. He was HIV positive too. We were legally married in 2014. Being diagnosed with AIDS was a tough pill to swallow. I embarked on a journey that would last for over 30 years, but I never gave up hope. Now I'm going to fast forward to July 2018, when I received another devastating blow, a diagnosis of myelodysplastic syndrome, which progressed to acute myeloid leukemia. It felt like life was playing a cruel joke on me. In February 2019, I underwent a bone marrow transplant. The procedure was not only aimed at curing my leukemia, but also have the potential to cure my HIV. My bone marrow donor had a rare genetic mutation, the CCR5 delta 32 mutation, which makes cells resistant to HIV. Months turned into years, and in March 2021, I stopped taking my HIV meds. After a year of weekly testing for HIV, there was no more virus to be found in my body. My HIV was in remission. Now I'm approaching 5 years since the transplant and 3 years since stopping my meds. My story is not just about me, it represents hope for millions of people living with HIV worldwide. It shows that a cure is possible and that we should never stop searching for answers. I'm eternally grateful to my team of doctors, researchers, and healthcare professionals, and my selfless anonymous donor who made this possible and gave me a second chance at life. And this is my hematologist, Dr. Mohammed Aribi at City of Hope. And this was my infectious disease doctor, Jana Dichter. The cure I've been fortunate to receive is not yet accessible to the vast majority of individuals. Therefore, my story should serve as a catalyst for igniting a collective determination to ensure that every person living with HIV has access to the same hope, opportunities, and chance for a cure. We need to challenge stigmas that cause discrimination and hinder progress, and unite as a global community transcending borders and ideologies to eradicate this virus once and for all. I'm going to be a strong advocate for HIV cure research and want researchers to study me like they did Timothy Ray Brown and the others of us who get cured in the coming years so that someday we can have a cure for everybody. Thank you for taking the time to listen to me today. Let's continue to spread awareness, support research, and work toward a world where HIV is no longer a threat. Together we can make a difference. Thank you.
Great. Thank you so much, Paul and Adam, for sharing your stories and the photos as well. I want to make sure you're visible to everyone. So I'm going to ask a few more questions just to kind of follow up on your story. So what is it like for you guys today? You've been cured of HIV. Does that mean that you have problems, and do you have any after effects from the procedures that you went through? So Adam, if you want to start.
So yeah, we do have. I think a lot of people don't realize. I think people sometimes they only concentrate on the HIV and they forget that we are a cancer patients. And when you have a transplant, you will become immunosuppressed. You have a lot of difficulties, a lot of challenges we face in a daily basis, and then it grows, it changes by time. But it's a lot of challenges, a lot of complications. You can be in hospitals. You can. I spent a lot in the first couple of years. I spent a lot of time in hospital, and I had to be isolated for a long time, so I could not be around people. I have to be monitored on a regular basis. So still monitored on a regular basis. So in my case, I've been unchecked every 4 to 8 weeks. So I had to get bloods to get checked, everything. So I have multiple teams of doctors looking after me regularly because complications evolve through the time. But yeah, if and medication, people don't realize the vast of medication I take. So I had a big box of medication to take with me everywhere. And
what are those medications for?
Prophylactic medication for transplant, for high blood pressure, for water retention, from my chest, for infections, for so many medications I had to take. And people not really even ask me for that. People just, how does it feel to stop the HIV medication? I said, yeah, I stole 1 pill, but I still take 30 pills a day. So it's just like people sometimes don't realize that. But HIV pill has stigma. The other one doesn't have any. Nobody really cares if you take 20 pills. Not really ask you, how many pills you take? Oh, wow. No, but they only cares about 1 pill, the HIV one.
Thank you. What about you, Paul?
Yeah, well, it's taken me a while for but I believe it now. I have some issues. I deal with dry eyes. I get sores in my mouth. and I have some issues with mobility with my ankles and knees. But otherwise, you know, I'm alive, and that's a really good thing. So that's my favorite part.
Yeah.
Do either of you have to take rejection medications?
No, it's the only transplant you don't have to. I mean, with every other transplant, you don't have to go in cyclosporine. You have to be taking the medication. With the bone marrow transplant, you transitioned after a year. You stop the medication, and that's the difference between you have the other triple transplants. You stop the cyclosporine on that.
And I took them for about 2 years after the transplant. I'm no longer taking them.
Yeah, it's a process to get into. You have to, your body have to get less and less needed to have that medication on you. I thought that I saw it's going to be in the medication forever because you're going to go to transplant, so that's kind of the act. But then and then they tell you that that is not the case. So only with this type of transplants, it's not.
Thank you, guys. We're getting close to time, but anything else, any last words you'd like to share with people about what it's like to live with HIV, or what people should know about cure research, since you're both involved as ambassadors to the cure?
So first of all, we are human beings. Sometimes some of the researchers forget, and some of the clinicians forget that when they're working in the lab, they have a sample, but that sample, when you find a cure, will change people's life. It changed our life. That's what we're here today, to kind of humanize the research, because sometimes it's just only in the lab settings and it's a case study. And sometimes you see in the slide, London patient, City Hall patient, but we are human beings, we feelings. And something people need to understand, when we cure HIV, the stigma and discrimination do not stop. It evolved into a different type of stigma. And that's what people need to understand. Some people feel like, oh, we got cured HIV and the Wizard of Oz is waiting for us in the yellow road. It's not. Still discrimination, still stigma. I have to endure stigma now in a different level. So I think it's for you to understand, even we find a cure, we need to well to understand still stigma and discrimination moving forward. And we need to change that narrative too.
Thank you. What about you, Paul?
Yeah, well, you know, I want to serve as an inspiration for people living with HIV, that a cure is possible. I totally believe it's going to happen for everybody, and I want to inspire the researchers and doctors. And you know.
Well, thank you both for willing to go public. I know it's a lot to come out in the public eye. There's a lot of media. It's sometimes negative attention that people get just by being in the public eye. So we really appreciate you following in Timothy's footsteps and joining us and being examples of what we're all working towards.
Yeah, like he has a pride here in Atlanta. So I was on the stand in Sister Love today. So I was talking to people. I was engaging with different communities. I'm engaged as well with the Latin community as well today. So to start to engaging, start to walking around different stools, start to understand the difficulties here in Atlanta. I thought for me to kind of able to help. How can I help? And then I need to go on the ground. So I think, thank you for the opportunity to be here in Atlanta this time, and for you guys to be here, because I want to inspire you, because with you, I'm not here. I will not be here today. So thank you.
Great. Thank you both very much. These at a time. So next up, now that we've heard from people who've been cured from HIV, and the reason why we have the opportunity to research a cure, we want to hear from the researchers themselves. The RID Collaboratory is one of the NIH-funded research collaboratories, and so if doctors, our head investigators from the RID Collaboratory would like to come up and sit in the hot seats here, they can tell us a little bit about the work that they're doing to find a cure for everybody, like Paul and Adam have been fortunate enough to have. Can we turn the projector for now? Oh, okay. All right. Yeah, we turned off the spotlight so you wouldn't be blinded. Doctors, take it away.
So I'll go ahead and get started. My name is Sumit Chanda. I am a professor out of Scripps Research in La Jolla, California. I work with Paula and Rafiq to lead this really incredible collaboratory. We've been around now for about 2.5 years. We're one of the new collaboratories, and just the science and the progress I think we made has been incredibly impressive. But on also, one thing that we as scientists, I think Adam pointed out, are not necessarily interfacing with the community, right? And so having Jeff really lead an effort that has opened at least my eyes in a lot of ways to shape my research in the direction that we want to go, both from a practical and an inspirational standpoint. So, Jeff, I just wanted to really acknowledge all the hard work you've been doing. It's just really been fantastic for us. And I'm gonna go ahead and start off. We can talk about our research and then I think go into a Q&A session. I can tell you what we're doing in our lab, and I'll let Paula and Rafiq talk about their approach. And to me, the cure is going to be like art, right? It's not going to be one pill. It's going to be multiple different approaches that we bring together, right? To really kind of hit the sweet spot where something that people will want to take. That's we don't obviously want. We need to have something that's better than art, right? As far as tolerability and compliance, and so that's really what we're shooting for. And so what we're looking at is going after the problem that is the HIV reservoir, right? So as you know, HIV becomes latent in the genome, which means it goes to sleep, and that makes it hard for the immune system to find it and get rid of it, right? And so one of the strategies I'm developing with Lars Paka, who's in the back there, really has led a lot of these studies, is finding ways to wake HIV up, right? And it's really a Goldilocks problem, right? Sometimes, we've developed drugs that either come in too hot or they come in too cold, right? And I think that where we are now, we may have kind of hit that sweet spot. And so, we're in a place where us and others, including people here at Emory, are finding that, we can reawaken the virus without making our immune systems go haywire, right? And so this is really what we're focusing on right now. And I think that is a critical component of a cure. And I think I'll let Paula talk about kind of the other side of that, which is, once you wake up the virus, how do you get rid of it? How do you purge it? How do you rid the body of this virus?
Thanks, Sumit. So hi, I'm Paula Cannon. I'm a professor at the University of Southern California. So it's kind of a long flight. And my football team did really badly yesterday, if any of you are watching. So yeah. While Sumit was talking, I was actually doing some math in my head, because I was thinking back to before I was an HIV researcher, and I've been studying HIV for 39 years. And the reason I study HIV was because I had a friend, Connor, back in the early 80s in Liverpool, which is my hometown. He was a musician, he got HIV and he died. And at the time I was an undergraduate at college and I was doing microbiology. And I actually thought my future would be in kind of beer, because I kind of like beer, and stuff like that. And Connor's illness and death and the lack of anything that anybody could do for him shook me profoundly. I was 20 years old and people my age didn't die. And I had this revelation that I could actually choose not to work on beer, but I could actually, reinvent myself as somebody who studied viruses and try and contribute, even in a very small way, to how we understood or how we could think about treating HIV. So that's kind of my origin story. And I've like literally 39 years. I'm kind of embarrassed it's that long, but we're still here fighting. So let me tell you a little bit about what I'm doing. And I also want to I also want to sort of recognize how profoundly important this community has been to a lot of progress in medicine. There's some very brave people in this room and in this community who've really taken treatments, extremely experimental treatments that are having positive effects, not just for people with HIV in our fight for a cure, but in other diseases. So I work on what's called gene therapy and cell therapy. They're sort of new types of medicines. It's a way of thinking rather than giving people necessarily a drug. Instead, we're thinking of ways to kind of ramp up or arm your own natural immune system to make it better able to, fight HIV. And these types of ways of thinking about new types of treatment are now providing cures for people with many cancers who previously couldn't be treated. So I do want to sort of recognize that there's a lot of very good side effects, if you like, of what we're all trying to do. And so as we keep, on our path ultimately to get a cure for HIV, I want to recognize that we're kind of curing these other diseases kind of, on the path as well. I'm working in particular on a type of cell in the body called the B cell. And B cells are the cells in the body that make antibodies. And I think everybody in the time of COVID now knows that antibodies are one of the ways we attack viruses. And we are trying to make B cells make better, more powerful antibodies that can really neutralize HIV. So that's what I'm working on. It's a type of cell therapy. It's very experimental. And again, I'm thinking that it could have benefits not just against HIV, but against a lot of other diseases as well. So I want to thank you all, because honestly, I look around and I see faces, and I think you are kind of my community. You're the reason I get up every day and go into, 5 days a week anyway, and go into work. And I love being part of this. It was great to hear from Adam and Paul and Jeff. I love them. There's a lot of faces, and thank you. You kind of make it all worthwhile for us.
Oh, so I'm Rafik Piasekali. So I'm here at Emory. Paula said will be working in science and HIV for 39 years. I've been for 44 years working in immunology. So I'm sorry, I beat you up. But I think what this 44 years really what meant to me is that, I became wiser and wiser, and I became more and more knowledgeable. And I think I started to work on HIV when I was Tony Fauci's group in '84, at the time when the epidemic was started. And really what struck me, because I also worked on cancer before, is how the community became engaged as soon as the epidemic hit. And I've seen a lot of friends of mine die in Montreal when there was no drugs, there was no AZT, there was nothing. Friends very close to me, and I think that was really gut-wrenching. And I promised myself, in fact, and that's the reason why I'm still here, that I will never retire before I ever make a contribution to a cure to HIV. So you're going to be seeing me around for the next 15 years, probably. I think hopefully before. I think my staff, my colleagues are probably scary because I'm going to still be around and bang on their heads. But I think my goal in life is really to bring a cure to HIV. And I don't think I'll be able to do it without especially the engagement of the community. Because in science, as scientists, as wise as we are, as bright as we are, if you don't know what you want, okay, if you don't know what's appealing to you, what is acceptable to you, we'll never be able to reach a cure. We need to get your engagement, and we need to communicate to you, and we need to work together like we do in Rate HIV in order to be able to get to a treatment that will be able to be acceptable to you and be implemented. I mean, there's seen a lot of drugs, a lot of compounds that have been tested that go nowhere, including, the famous HCV cure drug. They are not going, that still, the rate of HCV infection has not changed because there's a lot of people who don't take the drug, even if it means curing HCV. So I don't want to get there. I want to get to a treatment that is going to be acceptable to the community of persons living with HIV, and then hopefully we'll get to a cure together. So my science is a little bit out of left field. So all of you, when you go to HIV meetings, you hear about CD8 T cells, CD8 T cells, CD8 T cells. Now with Paula, you hear about B cells and neutralizing antibodies. But we work on, so I'm being told to stop talking or what?
Oh, it's an amber. It's,
Yeah, I've
it's an
been
o-
kidnapped, no? So what I'm saying is that a lot of you, when you go to HIV meetings, you hear a lot of work on CD8 T cells, on BNAbs. We work very much upstream of that. I mean, there's not a single innate immune response that will happen in your body if you don't trigger monocyte innate immune cells, which are, in more scientific terms, are monocyte macrophages, dendritic cells. And just to remind you, Ralph Steinman and others won the Nobel Prize because they discovered dendritic cells, which are really the initiator of immune response. But upstream of this, there's trigger of the innate immune response, there's the microbiomes and metabolites. These are small molecules which are being produced in your body by microbes or by what you eat, okay? And that's why I said, I mean, you are what you eat. And we are what you eat, and the eating, the metabolites, whatever you eat, is going to shape your immune response. It's going to make what we call Tregs, T17, B cells, all this, everything that in your body is being related by what you eat and the commensal bacteria that home you got. And that's really what you're doing. And this is what I'm convinced, and I put my hand in fire, is going to lead to treatments which are absolutely non-invasive. And if you look again, because I'm so old, I read a lot, and I read a lot about cancer, and a lot of lessons learned from cancer. And people are treating now cancer with diet, changes in diet, changes in the microbes. And these are fecal transplant with different bacterial communities, putting people on high fiber versus low fiber diet. And these are game changers. I mean, I've seen papers in the highest impact journals where they put people on low fiber, high fiber diet, and now they respond to treatment of pancreatic cancer, one of the most aggressive forms of cancer that exists. So that's my goal. My goal is to shift the paradigm. Yes, use immune modulators to sway your immune response differently, but not by doing, of course, using small molecules or compounds, but very differently than other people are doing, and really trying to implement diets and change the microbiome that will eventually trigger the right immune responses.
Great, thank you so much. And I've got to say, as someone who's been living with HIV for 40 years and doing advocacy work for over 30, it's humbling to see the scientific community and what they've done. And you know, it's great hearing your stories of what brought you into this. And it's all, HIV is human immunodeficiency virus, and it's the human element that brings us all here today. So thank you for that, because I've never known a group of scientists who are so humble. A lot of scientists are not humble, as you may know, but certainly in HIV and oncology, where, you know, early on, there wasn't a lot of hope. You persevered and you brought hope to us. So thank you for all the work that you do. And we want to hear more from everybody here in the room about the questions they have. We've just scratched the surface, and I know there's a lot that people want to know. We couldn't find a way to put that all in, so we thought you'd let you all lead the discussion for the next 15 minutes or so and ask the questions you'd like to hear. So I'm going to grab one of your microphones so you can share. Andy will go ahead and raise your hand if you have questions, and fire away. We want to hear from you.
Thank you very much for the work that you're doing. Thank you for coming out and giving us hope. Really appreciate you. Did get an opportunity to spend some time and meet Timothy as well. So I feel like I'm in high cotton right now. And the holistic approach sounds very interesting. I also was interested in finding ways to excite the virus out of the blood marrow and then find ways to capture it. But I've also become a vegan and have lived that lifestyle for over 35 years. Mm-hmm. And so, you know, the holistic approach does sound very interesting. Have the three of you collaborated at all?
So you're here, huh?
Yeah. So we definitely would love to hear more about that. If there's, there's really, as you know, I was also diagnosed in 1988, probably contracted in 84, was diagnosed with AIDS when I was diagnosed with hepatitis C. They said, don't worry about the hep C because you probably won't make it that long. But here we are through God's grace. And I know for a fact, even that there are a lot of people, just the mere energy of the possibility of a cure actually can, engender a lot more, I don't know, just the energy itself being out there, I don't know what it will bring, but a lot of people are afraid to dream about a cure. And so that's why the hope is important. What do you think? Is there something that we can do in the community to highlight your work, to make more people hopeful of the possibility of a cure? I know that you're scientists, but speak from your heart.
You want to go ahead?
Well, I was just going to explain to you why we collaborate together. So one of the ways that the government NIH funds, scientific research, the way it funds HIV research and HIV cure research is very different, because they looked at the group of scientists who work on HIV cure. We're a bit of a ragtag bundle of people, really, but I think they recognize that we do all work together. And so they've established what are called the Martin Delaney Collaboratories, and RID HIV is one of them, and ARRAISE is one of them. And they're kind of groups of real mixtures of scientists who all work together. So we're at Emory, we're at University of Southern California, we're at Scripps, also in Southern California. But we have Zooms together all the time. We work together. A lot of our people are here in the room and we all collaborate. So it's tapping into the fact that we realize that this, it's going to need us all working together. It's not just about, one scientist in their own lab in a silo getting a Nobel Prize. I mean, that would be nice, but failing that, we do all like to work together.
Yeah, I mean, I agree with her. Breaking down these silos are going to be key, right? I mean, each of us are bringing something to the party, but it's not a party unless everybody's there. But the point I wanted to really emphasize is that community advocacy is really what historically and even now has driven HIV research forward, right? And the NIH and Tony Fauci changed their mind about this virus because of you guys, right? And so we can't do our work without you guys doing what you do, right? So it's so important that you continue to advocate, right, to the politicians, to NIH, to say that, look, the job's not done here, right? We need to find a cure, and that those funds and those resources need to be put behind that so we can achieve this goal.
Yeah, one thing I should add to that is, the RID Collaboratory and the ARRAISE Collaboratory that's based here in Atlanta are part of 10 collaboratories funded by the NIH. Started with the $100 million that Obama gave towards AIDS cure research when he was president. And this was named after Martin Delaney, who was one of the pioneers. He's a giant on whose shoulders we stand, because he really engaged the scientific community and with the HIV community. And so this is named in his honor. We lost him, unfortunately, due to hepatitis a number of years ago. But I just wanted people to know that, this is named in his honor and we do this work in his name. Thank you.
So I want to mention that HIV, 20 years ago, when David Ho published his first paper on the antivirals, the headline was, "Is the virus stupid?" Okay. We learned from what Jeff mentioned earlier, it's not way more than the virus. And I think RID HIV really exemplifies this, because in RID HIV, we have virologists, we have immunologists, we have clinicians, we have behavioral scientists, we have a whole gamut, at least 6 to 10 different disciplines, which means, that, and we know that very well, that there's no freaking way you're going to get to an HIV cure if you don't engage all the different disciplines in a joint effort, to be able to get it. So I cannot do my work if I don't have Yair or Linus or Vince providing with sample from patients living with HIV. I cannot do my work if I don't have a virologist like Linus or others who can measure the virus in the most accurate way. I cannot do my work, I don't have Sumit trying to reactivate the virus and now deal with the immune system. Always Paula identifying way by which now we can stop the virus with antibodies. So really, it's really a collective effort, which is very, very different than the way I was doing my science, 40 years ago, where, I mean, we were doing science in silos, where 2-3 people working in a lab, addressing much smaller questions. But now the question of HIV cure is way, way bigger. And for way bigger, we need really to have much more aggressive and much more encompassing solution. And I think what we are trying to do all together is to bring an encompassing solution that brings together all our mental capacities and eventually, of course, with all of you.
Great, thank you. Other questions? Go ahead, Michael.
Yes, hi, my name is Michael. I'm from Seattle, and I've had the privilege of talking to people who live with HIV or are affected by HIV about this cure stuff that we're talking about. Some people already think there's a cure that's just being denied to them. Only certain people are getting it. Some people believe Magic Johnson was cured. And it's such a ripe field, I guess I should say, for all sorts of reasons why to believe those things. But you guys believe that HIV can be cured, or else you wouldn't be spending your effort trying to do it. So why is it that you think it could be cured? I'm not sure if you could tell us, each of you, why you think, individually, why you think there's actually a effing chance that this is possible. That's what I would love to really get an idea from you guys. Like, why should we put hope into you guys over all the other stories that have existed? I want to know why.
Michael, I mean, you should answer yourself the question. You have living examples of HIV cure. So, I mean, that means that HIV can be cured. And I mean, tomorrow you'll probably hear of other examples of ways to get to an HIV cure. So, I mean, we know, I mean, there's by bringing all our efforts together, tackling the virus, tackling the immune system, and tackling the immune system in very different ways, you can get to a cure. So, I mean, I won't say we know 100% how to get there, but you have 2 living examples of HIV cure, and there's a lot of ways in patients living with HIV that we've been able now to master the virus and to control the virus even after stopping therapies. So we have those data. We know how to get there. I think now is really to implement that on a wider scale, and that will take some time, but we know how to get there. And I'm really confident of that. If not, I can go to the beach and retire. So
I think I'm just like a profound optimist about what human beings can do. We went to the moon, we're curing all sorts of cancers. I mean, it's kind of almost mundane. I just assume we'll do this because everything we put our mind to, we do. Okay, it takes time and money, and we know those 2 things are kind of reciprocal. But also, I think I'm very inspired by the fact that, as Rafiq just explained very eloquently, that it's about when people get together, when scientists get together, and clinicians and community members and everybody, and we're all working to the same goal, that's when we get to ask the really big question and to take on the really big challenge, and it becomes kind of smaller. So of course we'll get there, just as we'll be we'll be at Mars next, won't we? And it's just, we're humans. Damn it, this is what we do,
Yeah, I just want to echo that. I mean, everything seems incremental until it's not, right? And I think that, if you went back 20 years ago and told me what we could do in science now, be like, get out of here. There's no way that, we're going to be able to edit genomes and, deliver all. So, a lot of things are coming together in a way that I think are so unique, especially in this field, right? I see the needle moving more than I've ever seen before, right? So is that a guarantee? No, right? But you keep trying and you keep plowing until there is that that transformation between kind of incremental and game changing, right? And then at that point it'll be obvious, right? And HCV is a great example, right? We struggled, and now all of a sudden, right, we have a cure, right? And it seemed like it was overnight, but it wasn't overnight, right? It was a lot of blood, sweat, and tears and a lot of incremental advances. But then when you get to that peak, everything changes, and we could be there. I can't tell you how long, it could be a year, it could be 5 years, it could be 10 years, but you know, this is why we here, right? We will keep trying and we'll keep going until we've found that kind of set of things that does work together to allow us to get there.
Thank you for mentioning hepatitis C. I think people forget that it was the protease inhibitors that were the game changer for HIV, and the reason many of us are still alive were the first drugs that successfully cured hepatitis C. So it's, as you're saying, it's all incremental, and everything, as Paula was saying, kind of builds into everything else. And same thing with the COVID vaccine. The mRNA platform was being studied for HIV. We don't have an HIV vaccine yet, but we managed to get one in less than a year for COVID, which is mind-blowing in the history of medicine. So it all matters. And you know, if you if you get a chance, write your Congress people and make sure that they continue to fund research, because it's keeping us, all of us, alive, not just people with HIV. Nina, I think you're next. Go ahead.
Hey everyone, I won't do a full introduction because you'll hear from me in a second, but I just wanted to bring into the room the other patients who experienced HIV cure without intervention. I feel like their cases often get left off the table when we discuss HIV cure. So even from an empiric standpoint, the human body has the capability of clearing viruses. Like 70% of people in America have had HPV and 90% clear it within 2 years. So I just wanted to make a mention of that, is that, you know, the body is an amazing thing.
I mean, I was going to add a comment, but I think your comment is very appropriate, because I think we, again, in my very old time, we used to work in silos. I mean, you work on cancer, we're on cancer. You work on viruses, we're on viruses, and there was absolutely no communication. Now, I mean, everything is open. I mean, there's crosstalk, there's lessons learned, and we learn a lot. I mean, people in cancer learn a lot from HIV, because people in cancer never believed that the immune system had any role to play. But HIV made a real difference by showing that the immune system played a major role in control of the virus. And that gave cancer people a lot of tools to be able to measure immune responses in cancer rituals. And then cancer moved ahead and developed immunotherapies they immediately implemented in cancer and moved on and improved. And now it's really time for HIV clinicians to learn from them, and now to be able to get lessons learned from cancer and apply all this to patients living with HIV. So, I mean, it's really, and that's true not only for cancer, HIV, it's true for cancer autoimmunity, cancer HIV autoimmunity. So the fact, I mean, that all the gates are open and communication is so easy now, that I think we are going to get to our goal, because we are interacting much more as a global community than just working in our labs or silos.
Other questions? Yeah, go ahead.
Good evening. I guess my comments are more of a gratitude for you guys, because, you know, I'm listening to you say, how can we believe that there's a cure? Hey, from AZT was the first thing they threw me on in '89. Take this and you will live. You know, so going from 20 pills a day back then to 1 pill a day, I do believe it's a cure. You know, listening to you guys, you know, so if the scientists could cut it down from 20 pills to 1 pill, so I know they could do that 1 pill to no pill.
Mhm.
So, you know, you do give me this hope, you know, because if you would have told me 34 years ago, I would still be here today just through medication. No. And like you said, the stigma behind this, you know, even if it is cure, will that stigma go away? But, you know, today I don't care. I'm just trying to live. That's the main thing. So I just want to thank you all for just being up there on platform.
Other questions? Go ahead and raise your hands. Don't be shy. We've got plenty of time. Yeah, one in the back there. Go ahead.
Hi, everyone. I'm Nadine Spring. I am inspired to see, you know, so many people in the community, people who have been cured, researchers all here, collaborating, partnering, and working towards a cure. Nowadays, we have PrEP, we have undetectable, and I believe in my lifetime, you know, we'll get to a cure. But one of my areas of interest happens to be diversity in clinical research and how we can make sure that underrepresented populations are represented in clinical trials, and that they are, you know, representative of the populations actually living with conditions. So we saw what happened with COVID, the COVID-19 vaccine, and the amount of pushback. I have a 3-year-old future PI here with me. Okay, I'll take your bodysuit. And my main question is, what can we do, in the community to foster that trust, build rapport so that when we do get to a cure, which, I know there's 2 individuals here who have been cured, but I'm talking about a cure that's more available, widespread to everyone living day to day with the condition. What can we do to ensure that there is uptake of, that cure when it does come around? And, that we don't face that pushback.
Yeah, I was going to say, but this is entirely why such an important feature of these collaboratories is our community advisory board and the community engagement that we have, because this is not an area we are experts in. This is the area you guys are experts in. I mean, Jeff, gosh, this is what you do like all day, every day. Yeah. So, I think our job is we try really hard to explain to you what we're doing and why we care and why we feel passionate about it. But ultimately, we need you guys to advocate, to advertise, and to kind of normalize what we're doing, quite frankly. You all know that it's been frankly, the bravery and the generosity of people in the sort of 1980s, especially who went into clinical trials when nothing was available and things were probably scary. And I think the HIV community has always been marked by that sense of people have bravery, people give back, and people know that they can get involved in clinical trials and it may not benefit them, but it'll give us some incremental information, it'll benefit somebody else. So I'm very optimistic about that, because I think this is something that is incredibly special and frankly humbling about people with HIV, the sense you have of helping others. So anything you can do to advertise what we're doing. No, again, I use the word normalize, but I think letting people know that there are going to be clinical trials available, and we deeply appreciate people being involved. And Jeff and his team, they do an amazing job, I think, of sort of educating people about it and educating people about the opportunities. I don't know. I feel like we are probably not qualified to answer this, so maybe Jeff.
I was afraid that would happen.
Yeah. Well, I just thought I'd better stop before I dig myself into a hole.
Well, you mentioned the community advisory boards, and that's a key feature of AIDS research. It has been from the early days when the activists fought their way into literally fought their way into the NIH and onto the networks that that are funded to do HIV research, starting in the 80s and 90s. And so, interestingly, a little story about this collaboratory, named after Martin Delaney, a famous activist. They didn't have any of this. They didn't have advisory boards. They didn't have community engagement. And we said, well, why not? And they said, well, it's basic science. We're not doing clinical trials in people just yet. And this was 12 years ago. Now they're starting to. And we said, well, wait a minute. You will be. And we need to be along for the ride. We need to know what you are doing. You need to know what the community needs. One of the things that we really emphasize, and somebody else mentioned it, is, the research you do, the cure needs to be for the people who need it the most. And the face of HIV is changing. It's, incredibly more diverse. It's more people of color, a lot more women than there used to be. And we're getting a lot older. You see a lot of gray hair around the room, not just me. And by the time we get a cure, the majority of people living with HIV are already over 50. And we're going to be a lot older, in the next 5, 10, 15, 20 years when this finally comes to fruition. So one of the things that we've been really promoting in our collaboratory is making sure that the research happens in the people who need it, including older folks, because there's a lot of research that happens in people who just got infected with HIV like 5 minutes ago, and they don't really have a reservoir. And isn't it neat to see what we can do with these folks? Well, that's nice, but I call that curing unicorns. How often in the real world do people find out immediately after they got HIV that they have it? And so that's kind of a dead end. So we're really trying to keep the researchers honest and say, look at who's in the community. That's why, we encourage them to come to events like this and, advise them on the sidelines as to who it is for and what it needs to look like. Go ahead.
So, I mean, I found out, I think the hard way during COVID that, you could build the best vaccines and the best drug. If people don't want to take them, it's useless, right? And so I think this integration with the community early, and yes, it is basic research, but we look at patient samples, right? And if we don't include kind of the diversity of the community in the samples that we're looking at, right, we're gonna skew our data, right? And so we really need to have representation from the beginning, so we can build a cure for everybody, and not just the samples that we happen to get or are focused on.
Question here. Go ahead.
Hi, thank you so much for sharing your work and your research. So as we understand, part of HIV treatment and care comes with having robust public health infrastructure to support that. So how can we support and engage with people living with HIV in low income or low middle income countries that are having a higher burden with the condition and not really having that public health infrastructure or medical or clinical support that we have here in the United States?
I mean, one thing it was very evident at the last meeting we just came out from the NIH was now, and I think it's a lot of the collaborators are really taking that initiative, is now not only considering a cure for US or Europe, but also considering to make a global cure. And it was very, very clear from our funders. And at the end of the meeting, there was a workshop, a discussion that included several members from Africa, from many other countries, where, I mean, what can we do to achieve a global cure? So it's already in our mind. There's already some of our collaborators who are implementing this, but I think in the next 2-3 years, you'll really see the engagement of many countries in all parts of the world that can contribute to that cure.
One other thing to add to that is that, right now, the way the research is set up, the basic and translational science happens in these collaboratories. And then once they're ready to put them into people in larger trials, that goes to another research group called the AIDS Clinical Trials Group. And I know you have one here at Emory, and they're all over the country and all over the world. And they have a very big community advisory board with people from all over the world, and they're very active. And that's where this happens. So we encourage you to get involved in the CAPs in your community and network with people in what we like to call the global South, which are also often, lower resource settings, to ensure that they're on board, they know what's happening, and they're advocating for their own communities. Because I've been doing this work for a long time, and you can advocate for other people. And I've had kind of arrogant researchers, this isn't pharma, not these folks, look at me and say, well, if that's so important to them, why aren't they at the table? So, there's a lot of stigma and arrogance out there, and we all need to step up, advocate for each other, and help people get to the table so they can advocate for themselves and their communities. Anyone else?
Just brief addendum, and yes, advocating for our demographic. My wife and I are a heterosexual serodiscordant couple, and very rarely are we at the table. So we need to make sure that the research is done. But hypothetically, when we find the cure, and we know we will, the question was asked about affordability. Hypothetically, and when I think about it, my question was, do we give it away? Is it sold because it's the cure? And it ends so much of what's going on now. I mean, do we give it away or do we sell it?
If you look at the example of HCV, the HCV drug, I mean, the HCV drug is made available in Egypt, in many countries that are affected, which are not US, which are not Europe. So that example already is there. I mean, even the Gates Foundation and the Clinton Foundation, others have already engaged themselves into making sure that the treatments are become accessible. So I'm very much like Paula said, I mean, it's an optimist. I think that's when a cure, I mean, is going to be available. It's not just a question of making money.
Well, and I think there's going to need to be a private-public partnership to do this, right? I think that in countries where the healthcare system couldn't support this, right, governments need to step in. I used to work in pharma, so well, don't hate me, but you know, there's unfortunately the system that we have, there's a profit motive, right? It costs $1 billion to bring a drug to market, and someone who's investing $1 billion wants a return on investment, right? So that's just unfortunately the way we've set up how we build drugs in the West, right? And so given that, right, fortunately, well, I think everyone should have health insurance, but you know, more and more people are having health insurance, right? But if they can't afford it, right, I think that this is a governmental and NGO imperative to make sure that the people who can't get access have access, right? It's, I mean, in a realistic world, it's going to be impossible to say we're going to give it away free to everybody because those drug companies, those pharma companies have shareholders and they need to make their money back, right? I mean, we don't have any skin in this game. We would love to give it away, right? But it's not our decision, right? And this is above our pay grade. So, but again, this is where advocacy comes in, right? I mean, yes, someone's going to need to pay for it. Let the pharma companies make their money off people who are insured in the US, in Europe, in Japan, but let's make sure that the people who can't afford it have access to it and tell our government that, look, you know, we need to get this out there, right? And you know, there's not a lot of times I sing the praises of George W. Bush, but you know, he did some really impressive things in sub-Saharan Africa, right? And I think we can follow that, right? If when the cure does come, that kind of program should be instilled to make sure that people who can afford access have access.
Sumit was talking about public-private partnerships. There's one called Caring Cross that is looking at this problem. They're looking ahead and saying, yeah, we're probably going to have something really complicated, really expensive. How do we roll this out to the rest of the world? So we did a series of webinars on gene therapy, and there's one that we have for this. So what we'll do is everybody who registered will email that, a link to that out to you, so you can watch that webinar and find out, you know, what people are thinking about and how they can address that really important question that you raised. Thanks. I think we've got time for one last question. Go ahead.
Hi, I'm Nuri Negbene. I am a public health professional working with people living with HIV. And one of the biggest questions we typically get, and one of the biggest recommendations typically made on a provider front, is around a holistic approach, as someone mentioned at the top of the session. So not just taking your medication, but also complementing that with diet and exercise. And I think for a lot of people, once they're diagnosed, that's also just a natural response, right? To try to change as much about their general health as possible for the sake of recovery. So to piggyback off of what someone said at the beginning, I'm curious to learn or just know more about what you've discovered so far in that realm. Particularly around the types of diets that you may or may not have noticed tend to contribute more to an enhanced immunological response, whether that's pescatarian, vegetarian, and then also how sustained is that response? Like, how long would someone have to remain on that diet for those beneficial effects? Would I have to be a vegan for 35 years? And even if I have one cheat day, would I be basically back to square one the next day? Just any information around that would be much appreciated. Thank you.
I think this is a field which is in its infancy right now. There's some very compelling and mechanistic proof of concept that can justify that. Where you can learn the most is in cancer, like I said, where they can put people for 4 days on high fiber, low fiber diet, and they respond to treatment they were not responding before. And also in vaccines, where, I mean, because you're vegan, individuals that take either vegan or ketone diets, they have completely different response to vaccination. And that up to 2 week 2 weeks of being on a vegan or a ketone diet. And I think for vaccine, at least, you know, that the response is going to be long lasting. For cancer, I mean, the proof is that they can respond, but whether they need to be put back on these diets every month or etc., that's still very much unknown. But I think that the field is that.
And I think one of the things we can hope to do as scientists is, you know, if the answer was, yes, you do need to be a vegan for 35 years. I know that's hard. But perhaps if we could say to you, here's why it works. Here's the things that are different about a diet that's high in plant fiber. Here's what it does to the bacteria in your body. Here's the little chemicals the bacteria make as kind of little gifts to us. And here's what they do as they're swimming around in our body to kind of make our immune cells better able to keep HIV under control. If we knew all that and we could explain it to you, you'd probably walk out of the room and be like, you know, hey, God damn it, you know, that kind of plant-based burger looks a bit better. So I think that's what we can do, because, you know, asking people to change diet is profoundly difficult. But I think if we really could nail down the reasons why changes in diet might work and give you that information, then you can act on that yourself and you can feel good about it. Yeah.
Dr. Cannon, can I ask you to expand upon the bacteria in your body kind of thing? Because I think bacteria to a lot of people has a very negative connotation.
Oh, yeah. Well, okay. So this is mostly what Rafiq works on. So I am totally going to step into his territory, right? Okay, like the whole of the middle of your body is just a great big pile of bacteria, right? And it comes out at the other end, and that stuff we all know. But bacteria are incredibly important partners to us in health. You know, they break down some of the food we can't eat. Otherwise, the stuff that came out at the other end would be a lot more uncomfortable to come out. I don't quite know how else to put it. But they've evolved, you know, they've evolved with human beings. Every animal, every species has different types of bacteria that live with them. And they're really, really important to us. And so again, you know, the relationship they have with us, we say it's symbiotic, meaning we both kind of get something out of the relationship. Oh my God, it's like probably the only relationship in my life that sounds like that, right? So, you know, so we give them food, but they produce these little byproducts. They produce these chemicals, and then they pass through from the walls of our gut and go into our bloodstream. And we're just starting to learn how incredibly important these little, you know, bacterial gifts are, and how they change and regulate and influence so many things in our body. And I think we're also starting to understand that when you disrupt that balance, because, you know, we all know the kind of Western diet is kind of lousy, even though it tastes good. So when you start feeding your bacteria things that are kind of maybe not completely natural, then they get upset and they change a little bit and they get a bit angry and gnarly, and we don't get those nice chemicals from them anymore. So many diseases of Western diet, it's not just the food that's wrong, you know, it's what it does to our we call it the microbiome. It just means the whole community of bacteria in our bodies. So again, you know, it's now that I know that, it's kind of changed how I think about food. I still love Ben and Jerry's. I still love steak, but I've been vegetarian now for 7 months. Woohoo! I haven't seen any great changes yet, but I'm hopeful. But again, what helps me to do that is just kind of being told the science, on learning about the science behind it. So there is a reason that good food is good for you, and it's through these kind of colonies of bacteria that we have in our body that are really, think of it as like another organ. You know, you've got your heart, your brain, your lungs, you've got your microbiome. It's a really big and important organ and part of your body. And it's kind of cool to think about it, really, isn't it? You know, they do more than just make poop. Okay.
Thank you for sharing that after dinner.
Since someone was stupid enough to give me a microphone, I'm going to steal some time real quick. I just wanted to explain, like, maybe from a 30,000 foot level, you've heard about the Martin Delaney collaboratories, key word being collaboratory. There are not just 3 people, there's many scientists in this room, but there's many, many more elsewhere around the world that collaborate with one another. And they are all just like you. They have hearts that beat. They put their pants on, they put their shirts on. They're human. And if you can't get a sense from this panel right here that there's a lot of love and caring for humanity, then you weren't listening. And I know that the people in this room, you are all intelligent, you're here for a reason, but we all know people that don't trust folks like this and our doctors and things. So if you get the opportunity, please, please take the time to explain to your friends and acquaintances what these folks are like. They're just like you. They want the best for everyone. And we're really lucky to have them working for us. So, you know, that's just my little spiel. Don't forget about the love, the humanity, the mission that they're all on. And it's just not them. There's a lot of them around here. I'm looking at y'all too.
Yeah, I mean, just to follow up on what it says, I just want all the members of Read HIV to get up and so you can recognize them. So please, Read HIV, you stand up, and
including the government folks.
They span all ages. So thank you.
Great,
Thank you, Jeff, for organizing this.
Absolutely.
Yeah,
Thank
and
you
all
so
of you
much.
for your great questions.
We appreciate you sharing your time, and we're going to take it from the science and the bench and the laboratory to the people. So the next panel is going to be talking about clinical trials experiences, and with clinical trials happening right here in Emory. Yeah, have you stand if you want to be here, anywhere you like. Get chair, any chair. Peter. Yep, one more high chair for you. Yep. So the three of you will have two microphones to share. Okay. Okay. And there's one at the podium too.
The last day of Hispanic Heritage Month, and it's National Latinx HIV and AIDS Awareness Day.
That's right.
That's right.
Latinx representation.
Sorry? Okay. We'll be kind, Vince, I promise.
Oh, no, go at it.
Yours isn't the first study of mine.
This is transdisciplinary partnership. This is a word we need to make sure people understand.
Hello, everyone. Actually, I'm sorry, I forgot where I was. I'm in Atlanta. Hey, y'all. I'd like to invite everyone that stepped outside to come back in so that we can have a very robust conversation, maybe. I am Bridget Picou. I am a member of the RID Collaboratory. I am a nurse by trade. I do HIV advocacy by work of heart because I've been living with HIV for the last 10 years. It does my little 2 cents on what's happened so far is that I am a person who has a dual perspective on life with HIV from both a clinician, from a clinician standpoint, and also from a person living with HIV. I am an HIV nurse. I consider myself to be an HIV nurse. I'm HIV certified, AIDS care certified, and it is my pleasure to be able to give back to my community. I'm going to let the folks that are here introduce themselves. We're going to talk a little bit about community involvement in research, involvement in research trials, and address maybe some of the questions that were asked about how we involve community and how we involve all of the people who are affected by HIV, and a little bit, I think, about trust as it relates to getting involved in clinical trials. So I'm very much each one teach one person. So hopefully you take what you learned, teach it to someone else, and that's how we reach community. So I'm going to pass the mic and let everyone introduce themselves.
Thank you, Bridget. I'm Vince Marconi. I'm at Emory University here in Atlanta in both the School of Medicine as an infectious disease doctor and have been taking care of patients with HIV for about 25 years. And I also work in the School of Public Health and Global Health and have been working not only in public health here in Atlanta, both at the Ponce Clinic, which for those of you who are not familiar with, it's the largest clinic for people with HIV in the United States. So it's actually a fairly prominent place and a very privileged place that I've been proud to work there for the last 15 years. And I also work at the Atlanta VA's HIV clinic, which is the largest HIV clinic for a VA hospital in the country as well, here in Atlanta. And I also work in Africa, in South Africa, Uganda, and Ethiopia, and have done so in the last 20 years as well. And most of my work has been in sort of two areas. I work both in helping people stay engaged in care, make as much of the barriers that exist for patients getting in care and staying in care minimized. And the second area is trying to find ways to slow the aging process down for people with HIV. That's my primary aim, really, in my research now, and how that has intersected with the cure world. We'll maybe talk a little bit about that's been discussed already, and it's through the immune system. So it turns out that intersection of reducing inflammation and helping retrain the immune system not only helps curing HIV, as was described by our scientists that were here before, but also helps improve those age-related comorbidities. And that's what our studies are. We look at the brain, cognitive changes, cardiovascular disease, kidney disease, frailty, cancers. And we use, as was asked here earlier, is comprehensive ways of doing this. So yes, I do work with drugs, things like JAK inhibitors. Some of those have also been repurposed in COVID, like baricitinib. One was also in the most recent, the Geneva patient. Some of you may have heard of this person who went through a transplant. The drug that they used to help them in their graft versus host disease was a JAK inhibitor. So that's the same drugs that we have been studying here at Emory for the last 12 years, but also through non-drug interventions. So we have exercise studies that we're doing. We have meditation studies that we've done here at Emory and have published on this, also sleep studies, food. So we look at the whole mind, body, spirit paradigm and take comprehensive approaches through a transdisciplinary partnership, which we'll talk about earlier, that puts the patient and the community at the center. It's developed with that, and it's developed through relationship. Someone asked earlier, how do you do that? How do you bridge collaborations? How do you help reach underrepresented and underserved populations over the years that have not been a part of research? It's really through relationship. You know, we can advertise, and I think all those things are great, and we can ask our community partners, please go out there and get more people involved. But it's actually through relationship. It's through going to barbecues. It's going down to College Park, to people's birthday parties, which I've done in my patients' houses, to their weddings, to their funerals, and spending time and asking what it is that they want and trying to find out what it is they need, and empowering and putting them at the center. That really is what enables those trust issues to be improved. So that's the role that I think that we can serve here. And I think we're very privileged to work with people like Nina and like Peter and Bridget to actually help move and advance the things that you all want, whether it's long-acting therapy. Maybe you don't want a cure, you want long-acting therapy, or you want to have your age-related comorbidities taken care of. Those are the things that we put as a priority, and cure is just as much a part of that.
I'm gonna let Peter go first. Go ahead. Just an introduction, and then I'll introduce myself.
My name is Peter Thibodeau, and I'm with the ACT, the global rep for Emory University, located at the Ponce Center.
I guess the study that you participated in.
Right, I'm at the ERASE as well as the RID.
And I'm Nina Martinez. I let you go first because I was like, let me think about what my affiliation is going to be. And I just have to say my affiliation is to the cause. I've been living with HIV since 1983. I'm one of the country's first transfusion acquired HIV cases, San Francisco, 1983. Yeah. If you know the Yoda statue in San Francisco, that is where I also acquired the force. And if by the force you mean HIV, then that is correct. I sit with Bridget and Jeff Taylor and Andy Cates and others on the RID HIV cab. And in December and January of this year, I did participate in the RID HIV clinical study. So I'll start the conversation by saying it's the last day of Hispanic Heritage Month. So that's why I decided to go first. And it's also National Latinx HIV and AIDS Awareness Day, and I'm fully aware. And part of my motivation in participating in clinical research, I'm 40 years old now. I've had HIV since I was 6 weeks old. When I was 19, I decided to participate in clinical research, like a lot of people, as a way to give back. I was diagnosed as a kid at the age of 8, kind of thankfully, luckily, once they figured out all the pediatric dosing issues out with AZT, I was diagnosed after that. And, you know, I spent the next 20 years. So I recently just kind of retired from clinical research because if some of you may know, I became the country's first living kidney donor with HIV. In 2019, I donated a kidney to another person living with HIV. And recently co-authored, I'm the second author of the paper in the August 2023 issue of the Lancet Regional Health Americas, entitled Living Kidney Donors with HIV Experience and Outcomes from a case series by the Hope and Action Consortium. My short-term memory is terrible, so the fact that I could remember all that is amazing. And I knew I was going to step down from participating in clinical research. And I thought to myself, you know what I don't have in my portfolio? An HIV cure study. Because it's really hard for very treatment experienced patients like myself, although not that experienced, only a PI for 10 days, never an integrase inhibitor. So I wanted to keep my options open, and my remaining kidney is very happy about that. So it was actually last year's RID HIV meeting in Palm Springs. I didn't join you guys because I actually acquired coronavirus on a flight home from NIH, finishing a year 10 study visit. Had been fasting for a fibroscan, tried to sneak a snack on the plane, and the unmasked person coughed. And I knew it was game over. So I knew I wasn't going to Palm Springs. But it was at that time I actually reached out to Vince because I do have a hard time finding local studies in Atlanta to participate in. And I heard him talking about how they do leukapheresis to get white blood cells. And I'm not a very large person. And actually the first study I did at NIH in 2003 at the age of 19 was I donated white blood cells. And they had to use pediatric equipment on me. I weighed 98 pounds. I made it to the end of the procedure, but then I had like a citrate reaction. So first ever clinical research study, first adverse event. But the thing that made the difference to me is that the laboratorian from NIAID came over from her lab to the clinical center to thank me for my donation. And that really imprinted on me, you know, that somebody was grateful for the opportunity costs that I gave up to be there that day to donate white blood cells. But to round it out, you know, donating a lymph node to HIV cure research is a very big ask. And I mean, I personally do think it was a little more difficult than the kidney, and it's educational to disclose what happens. And, you know, as much as you can explain informed consent, you know, after 20 years, I have a few things to say about research. One, patients should get the informed consent before a screening or enrollment visit, because if we're all acknowledging that people with HIV have cognitive issues, sometimes it's going to take people a while to think of the questions that they should be asking. Donating a lymph node through RID HIV was my third surgical consent. I mean, obviously with the kidney donation, I have 8.5 months to think on that. But a same-day surgical consent, particularly for research, in my opinion, can be a bit coercive. I had donated a muscle biopsy when I was 20 to a NIAID study, and you know, I didn't get the informed consent ahead of time. The surgical consent is again done same day, but when somebody has already booked the OR room in 10 minutes, you know, and you've already taken the time off of me, I was a college student, like how open do you feel about saying no to participation, especially when you know that you want to help? So with these two very different experiences between the muscle biopsy and the kidney donation, and I come over to RID, you know, it was great that the leukapheresis I didn't have to do again. They wouldn't do it on me because it was a safety issue, but there's an alternative. You can donate a cup of blood. and I was willing to do that. There's a fecal sample involved. So don't say I don't give a you know what about research. Because I've done it twice now. The other one was for the diet study where they're looking at, you know, differences in microbiome. But when it came to doing the lymph node, I am someone who I tend to be that patient that does have kind of the adverse reaction. So in my case, I was allergic to the Dermabond, and it is written in the informed consent. But one of the things that I didn't feel was explained was how to recognize that you're having an allergic reaction when your skin is covered by the glue that's covering the incision. And it took a little bit too long for my taste for people to get that I was having an allergic reaction. And I'm very open and upfront. I've been through the research process. Like it's off-putting while I go through it, but it's important to me. If you don't disclose what is happening, you can't make any changes to what is happening for the next patient. So I wanted to you know, I didn't want any other patient to go through what I went through, but I knew that, you know, there's something in my body after 40 years of HIV from San Francisco, from 1983, never a protease except for 10 days of anazanavir, which can go kick rocks. That there is something to learn. So some of the battle wounds, trailblazing doesn't come without a little bit of sacrifice and all of that, but there are things that, you know, patients, they incur the opportunity cost to be a part of studies. And the reason that we have so many white cisgendered men in table 1 is that is who can most afford those opportunity costs. So it's not necessarily an issue just of compensation. It's the way that we're supposed to mind researchers' competing priorities. I think researchers and scientists need to appreciate the opportunity costs we give up to show up for table 1.
Oh, yeah. Absolutely. Those are great points, Nina. And there's a couple of things that you addressed that I'm going to come back to a little bit. Peter, why don't you talk a little bit about your motivation for getting involved in clinical trials, and if there was a lesson that you could teach to someone who's never been in one, what would that be?
Well, first, I've been diagnosed with HIV since 2007, and it wasn't until about 2010 when I got involved with HIV, HIV research, because of my physician at the Pond Center. This is a research clinic. From then, I became a more advocate for treatment, and now I'm on the cure side, and it's only been, what, a year this year? I've taken the 2 treatments, the two cures. And what do I have to say about that? It was an experience. It was a different experience I never experienced before. I never had any surgical experience, but when they cut into me.
That's such a scary way to say it. But no, it's important that people hear that that's the perspective, right? It's important for researchers and clinicians to hear that that's the patient perspective, that that's how it feels. And that's why I asked you about that. So talk a little bit more about the actual trial itself and what you gained from it.
Well, the trial itself, the surgical procedure went fine. But then afterwards, I got sick, flu-like symptoms, and my incision got infected. So that was another 6 weeks of healing. But during that whole period, during that whole time, I kept on saying, I have a hole in my leg. I have a hole in my leg. But I gave myself to research. I'm dedicated to research. So I didn't have any problem with that. It was just my mind was playing with me. And it was me for Dr. Vince and his team to hold my hand every step of the way.
You didn't hold my hand, Vince.
You know.
It's cool. I'm not a patient at the Ponds Clinic. That might be it, but that's okay.
But his team is very compassionate.
Yes.
They call you on a daily basis. Are you okay?
You participated after me.
Right. Then again, you have 40 years experience over me, and I'm 63 Tuesday. So I'm glad that they were able to take my age group and experiment on that, because us we as older generation, we need more experience, we need more cure studies.
Yeah. It sounds like that aside from the fear of being cut into, there was a trust factor because your team showed up for you, right?
Right.
So Vince, what would you say? How does your team create that bond of trust? What's the most important part of that? Is it the informed consent? Is it the follow-up afterwards? Is it what is it that you think creates the bond of trust that's needed for people to not only get involved, but stay involved?
Yeah, I think as Peter said, it's sort of being there is number one. And there's also taking what the patient says at face value. I think this is one of the things in, whatever number of years that I've been a doctor is there, if it doesn't fit into a neat box for a lot of us as providers, then we often don't hear what's being said as being real, right? A patient says, I think it's because this and that happened. For example, Peter being sick, right? One could say, well, it's just a flu and that's what's having the issue and that's what's causing the pain. But making the connection that no, this feels different and that day I felt different than I should have felt. It's easy to dismiss that. And I'm saying that in full disclosure, we've all been there as human beings, right? Family members, friends, loved ones. But you do have to go the extra step and you have to trust, which is a leap of faith that isn't always available for us, right? Whether we're tired, whether we've had bad days, it's very easy to kind of write things off if they don't fit into neat categories. And so I think taking the time and listening and saying, okay, let's investigate this further. Let's hear how you're feeling and how this is affecting your life. And that I can say, and I'm very grateful if our team over there, you can raise your hand. Many have showed up here. Thank you so much. This is an amazing group that come from all backgrounds and walks of life and have worked in these areas for many, many decades together combined. They are incredible and they're attentive and they're listening and they bring to us the issues that need to be addressed. And I think that's really what makes the difference. And then I would say for our, not only as patients and community members, but as partners working with individuals who have had experience with research is absolutely critical. And I think it was mentioned earlier, actually, Nina even said it too, about sort of white cisgender men and why that is the same representation. You can go to San Francisco, you can go to Boston. These are places where I've worked, where there are just lines out the door for people to participate in research. And over, and this is in Europe too. Our collaborators working there as well know that the same issue exists for them. So you see the tables in these research studies are always filled with that same population. And there's a reason for that. It's not just the distrust, and we need to put it even beyond that. There's also all the challenges, like you're saying, can you take the time off to just participate in research? And if something goes wrong and how that throws off an individual's life, and if they're having to work or if they're a single mother that's caring for multiple children, that's difficult just to get into care, let alone to then volunteer of your time for something that isn't going to bring you direct benefit. That's a huge ask. It's a really huge ask, right? And if you're living just above or even below the limit of poverty, that's just a bridge too far. So I think without understanding that and without being in tune with that, we're going to keep reinventing the same wheel. And it isn't just about advertising and trying to level stigma and distrust. There's a lot more that goes into it than just that.
I think part of that too is that researchers, clinicians, pharma, people who design the trials need to recognize that it's not necessarily difficulties. It is, there's layers. There are opportunities that need to be addressed. It's changing the way that we think about how we approach people who are not traditionally represented. I mean, let's just be real. So we need to change the way that we approach this idea that white gay men are always willing and Black cisgendered women are not, because that's not the case. You just have to approach them differently and recognize that it's not difficulties, it's just layers and nuances and different ways to think about it, I think. I have a question for both of you. As people living with HIV, for me, it was a very scary thing in the beginning, right? With the diagnosis and not knowing what was happening with my body. And I found that the more that I learned, the better I felt, right? The better I felt like I could live with this. Was there a particular lesson during the trials that you learned about HIV that made your life better, improved it, made it easier, made you feel more confident, something like that?
This one's all you, Peter, because when I was diagnosed with HIV, I thought it meant I was related to Magic Johnson, and I was okay with that.
Well,
even now, Nina. So the way that the way that life is now for you versus the way it was versus how it was when you were Magic Johnson's little sister.
Sorry, my short-term memory, the question was again?
After having been involved in clinical trials, are there ways in which you look at HIV differently that have improved your life?
I mean, I guess the only one I can think of is, because I did a lot of like survey studies, blood studies, a lot of non-invasive studies first. So I was that kind of research volunteer for 16 years before I gave up the kidney. So for me, donating the kidney was really an opportunity to turn HIV stigma on its head, because when we all grew up in an era, I mean, you guys were fighting HIV while I was fighting my diaper, but still, when we came from the perspective that HIV was people with HIV took lives, was essentially what people thought. And then here I was giving life, and in a way that didn't require me to reproduce was a bonus. And to know that whatever they learn from any samples there, I'm not particularly fluent, but it is my understanding that doing HIV to HIV transplants or taking organs from donors with HIV and putting them into recipients with HIV who need a transplant, something about that mechanism of viral transfer or not, because they haven't really found any evidence of superinfection, is informing cure research. I look forward to learning a little bit more about that. But that for me really pushed it from HIV as a disease of maintenance into, people with HIV could be part of the solution. I think a lot of people forget that.
yeah, when I got diagnosed in 2007, I threw myself in education and research. Since then, they taught me that life is worth living. Because the first time I was diagnosed, the first thing I thought it was a death sentence. It's no longer that. It's a life sentence. There is a cure.
Hopefully not. Hopefully we get that cure.
Hopefully we'll get the cure. Hopefully we'll get the cure.
Yeah. Okay, I'm gonna use my outside voice.
Yeah.
I have one. I'm in the South. So rather than a life sentence, I always call it a life process. It's a new life process. It's a new way of living life. And we are almost out of time. Well, we're over time, but good. I feel like it's a good conversation, and I have other questions, but I don't want to ask them. I want to give you guys an opportunity to be involved and ask some questions. I'm just gonna run around with the mic. I got the energy.
I had one thing that I had hoped Vince would speak to, which is after my copious feedback session with him and his study staff, I hope that you would say a little bit about how the process for RID HIV got improved.
Yeah, great question. So, all right, thank you. Sure, yeah, that's a great question. So RID and ERASE, you may have heard both of these acronyms just said earlier in the dinner session, are two of these Martin Delaney collaboratories that are focused on curing HIV. And so the goal is to try and understand, for people who are able to really keep the virus at a very low level, even after they're undetectable in their body, right? So some people who are undetectable have higher levels of the virus still in their body, and others have lower levels. And so one of the key questions that we're asking in this particular collaboratory is, why is it that some people have lower levels on their own and others do not? Taking the same medications. So in a room whole bunch of people, let's say, are on Biktarvy. Some have really low levels and others have higher. And so trying to understand through the microbiome in the gut, through their immune system, through other metabolites that are going circulating in their body, through their own habits and various things that they do in their life. What is it that allows some people higher or lower? And can we actually leverage those through both medications, diet, some of the other things we said, to give to the people who don't have that benefit? And can we then cure HIV through it? That's what RID is primarily focused on. There's some other pieces too. So our clinical side, where both Nina and Peter were able to participate, is to take blood, stool, and tissue, lymph node in particular, and the lymph node in the groin is where this one is obtained. Yep, that's the cutting, exactly. Is where you can get access to spots in the body that the virus lives at much greater levels than even in the blood. So for example, when Paul and Adam, after they had finished their stem cell transplant, they had to go through very rigorous, even well beyond those investigations to find out every single part in their body, bone marrow, in the spinal fluid, all of these areas. Are we absolutely sure there's no virus? You know, even questions, and some of them had, for example, in the kidney. Is it still in the kidney? You know, maybe not doing a lot of harm necessarily, but is it there? And so in order for us to really get at a point where we can get a cure as effective as getting it out of the entire body, we do need to access, and we have other studies that go into the spinal fluid, we have some that go into the gut. We need to access these really hard to reach places. And so that's what the clinical side of this study is doing. And we give those specimens over to our colleagues who work in the laboratory side, and they look at not only is there virus, but what is the immune system doing around that virus that's keeping it at bay or not doing that so well. That's the main question. Absolutely. My pleasure. So how have we changed it? And this is, again, and I'll use this term again, transdisciplinary partnership. This is putting Nina, Peter, those of you in the room, both if you are living with the HIV or if you're a part of the affected community in whatever way, is working with us through these discussions, through the CAB, coming to me directly. I do this all the time. People call from all over the world, ask, you know, can you change this? Can you do this differently? And one of the things through Nina's experience is bringing more of that surgical explanation up front, right? Even to the details of what's going on to help people understand, okay, this is what's I'm to expect, and this is how we can make that experience easier for you. So another thing that we've brought through the study through patients is Uber Health to bring people to and from. Okay, this is something the last couple of years that you have participated in, makes that easier. They don't have to worry about, I got to get transportation. Can I get someone to help me? That's come through patient activity. Changing in the consent, for example, changing the wording that's used, talking about things like allergic reactions. Okay, that hurts, right? It hurt a lot. Yeah, and you know, it's not just, oh, it itches a little bit, I got a little mosquito bite. It was very painful. That I have not seen in my whatever 25 years of being a doctor. I've never seen that kind of a pain. When she called and expressed, I said, this is, and we thought you had the infection like what Peter had. And it wasn't. It was just, it was not just, it was an allergic reaction. So that kind of feedback and working together, not feeling as if there's a barrier that, oh, I can't be a part of this. Absolutely not. We want you to publish with us. And we've done this before, and Jeff can speak to this and through the ACTG. We want you to collaborate with us. We're doing this even in COVID research and long COVID research. We need to do this as a partner. And I think it may have been Nina or someone else was mentioned, maybe Bridget earlier. The solutions come from the community, not just the questions. That's a big deal, pushing it to the point where we say, well, we want the questions to come from the community too. We go a step beyond that. We believe the solutions are there. Okay. It may not come out in the same jargon and all that people, you know, up on the stage may be using, but you listen, Daison, you pay attention to those things, right? Our folks in Africa where we're working, our solutions for what's helping, someone asked earlier, how do we get therapies to, you know, low income settings, for example? We find those ways by working with the partners and asking them, what are the ways you think we should be solving this? So please, I highly encourage, don't feel that there are barriers with us. Don't feel that there are walls. You call me, you email me anytime. I'm open for that.
I absolutely love that you use the word partners and you're using it consistently. Many of us in this room are language Nazis when it comes to the language that's used to describe us, right? We're not infected people. We're people that are thriving with HIV, hopefully, people living with the virus. And so I absolutely love your attention to language, and it shows and builds those humanized connections between those that do the science and those that walk the walk. So it's wonderful to see. You have a question, Ms. Danielle.
Thank you. So I wanted to thank you all again, especially Peter and Nina, for sharing your stories. Nina, there was something that you said in particular about the informed consent process and how it can be perceived as coercive to give someone this, 20-page document, single space, front and back, and expect them to be able to feel empowered to say no, even if in their, normal life they may not have the capacity to do so. I think it's hearing your story sort of brings together the advocacy that we have around supporting diversity in clinical trials. And I think oftentimes that's missing, the humanization piece. So again, thank you to you and Peter, but I just had a question. When you said you had a citrate reaction,
Yeah.
can you say a little bit about that for folks who are lay in the room?
I'm not a doctor, but gosh, it's essentially like, I think it's when your calcium level drops. So because whatever solution they put through the machine that helps separate out your blood cells, like it affects the calcium levels in your blood. So it happens when your calcium levels drop. Did I get that correct? Goodness, that was 20 years ago. So what ends up happening is that you might pass out, and I sort of do remember my hands in front of my face and things like that. And a lot of people will say, oh, you shouldn't share this because this will make people distrustful. Look, crap happens in clinical research. We know this. And what's educational is to say what happens and what happens in the process that gets improved, because we are working together, and I don't think that we do clinical research a service by just telling you the good stories. There are complex stories, and honestly, going through those adverse events doesn't change my view of clinical research. It is what do the PIs do with the feedback that I do give them, because honestly, nobody wants to create more work for themselves. So having people like Vince, who I think we must have exchanged 60 something emails over the course of my participation, it means a lot that again, it's tough, but we'll get to the other side together. And that's all you can ask for. His commitment to connection to people is really what has made him one of the most trusted healthcare providers here in Atlanta for people living with HIV.
Let me take a moment, and because I believe that we are human and we all learn. My mother is the one who taught me the phrase grammar Nazi, language Nazi, and I repeated it. And I shouldn't have, because it's insensitive, and I take responsibility for that and apologize. Your question, sir.
I just had a question for Vince. We're talking about inclusivity in research, and percentage wise, are we represented in your research? I mean, what are the percentages race wise? I mean, put it right out there. I mean,
fantastic question. So from our site locally, so first of all, our clinic, the Ponce Clinic, which is the main one that Peter was just describing, Nina too, is about 80% or so African-American blacks, including people from the Caribbean and Africa as well. And that's about what our representation is in the study as well. So to me, that's amazing, right? To be able to contribute from our site here locally into the larger cure realm. We are just with this study alone are changing the demographics of cure research in the collaboratories worldwide. So that's really amazing. And the other group too is women. So 25% of our clinic are women. And I think we're over 25%. Ali, is it 50? Are we close to 50% women? Which is astounding, right? Again, that's about the numbers that we see in my cohorts in Africa, working our patient populations. You don't see that in the US. And I think that's pretty astounding.
It is absolutely astounding, and it's something that should be repeated. I saw another hand. Did I? Yes, I did. I know I did. Okay, so this will be the last question. Oh, hey, I got you. Oh, the people on Zoom.
Okay, you know, everything that you're doing is inspirational, but doing this research where I want to become more involved, I always see 18 to 45. Some of us are not 45 or 18. And it kind of confusing because even, you know, living with this diagnosed for 34 years, I want to become part of research, but it's hard to find something to get into. So can you explain, you're working on it? I get that probably. But I just want, I want to be a part of this global to do what I need to do for someone else. But it's hard to find. It's always 18 to 45.
I can relate to that because again, for the 20 years that I've participated in clinical research, the majority, like all but 3 studies, have been in Maryland. And I don't live in Maryland. I live in Atlanta, Georgia. And it can be, if you don't know the process, it could be easy to be dissuaded by the explicit inclusion criteria that they make available in their recruitment studies. And what I will say is ask anyway, because there have been, a lot of times investigators will copy and paste parts of informed consent, parts of their protocol, and it doesn't have a scientific basis. So I'm not going to say ask every single study, but sometimes, studies will modify their criteria to allow you to participate. That's happened to me a couple times because I am such a unique, in my clinical history, patient that, but I'm also a good research participant that they're like, okay, we will change it so you can participate, Nina. And again, when only 1% of Hispanics ever participate in clinical studies, I certainly will make my way in.
The question part is really important that she said, always ask. And I also want to bring into the space that it's not just invasive, like studies that we can get involved in. It doesn't always have to mean giving up leukocytes. It doesn't have to mean giving up a kidney. It doesn't have to mean, right?
Say the 16 years before that were none of that.
Yes, yes. And so it's keeping in mind that there are other ways that you can participate in research that are just as valuable and just as meaningful. And I know Jeff is probably going to tell you about the website you can go to so you can find out where there are clinical trials happening and other ways to get involved.
Thank you. Yeah, clinicaltrials.gov is the government database. So clinicaltrials.gov, we'll include that in the follow-up email we send. And you're absolutely right. I'm long past 45 myself. And as I was saying earlier, the face of HIV has not only many colors, one of which is gray. And we push back on this all the time and hard. And it's having a big effect in not only in cure research, the ACTG that does treatment research. We've gotten them to push it from 50 to 60 to 70 and drop it all together. And we ask the same question every time, what's the reason for this? Like Nina said, often they just copy and paste from earlier trials. It's a lazy way. And so, yeah, just keep asking. We'll get it eventually. That's how we got where we are now.
Thank you guys for participating. Thank you to the panelists. I hope that everyone here, researcher, community, each one teach one, make a new friend, talk to somebody you never talked to, ask a question that maybe you didn't get a chance to answer, learn from each other, connections, like you were saying, relationships. Community is equally as important as science, and science is as equally important as community, because without each other, we don't have an opportunity to move forward. So thank you for being a part of this. Jeff probably has some other announcements. Yes?
Yeah, just a few things. Yeah.